Hello viewers, my name is Dr. Rajiv. Welcome to my education channel YouTube Surgery and Orthopedic Education. Please consider subscribing it as well as share it to your near and dears to help them in their preparation of MBBS course as well as postgraduate entrance examinations. Also, don't forget to press the bell icon below so that you never miss an update from us. Today's discussion is about Asiatic cholangiohepatitis. It is a chronic infectious disease of hepatobiliary ducts caused by a trematode Clonorchiasis sinensis. Asiatic cholangiohepatitis is also known as Oriental cholangiohepatitis, recurrent pyogenic cholangitis, and Hong Kong disease. It is a hepatobiliary disease characterized by recurrent bacterial infections of the bile ducts leading to the formation of pigmented intra and extrahepatic bile duct bilirubineate stones and biliary strictures. There is an increased risk for cholangiocarcinoma also. The disease is caused by hepatobiliary invasion by a trematode Clonorchiasis sinensis, also known as Chinese liver fluke and Oriental liver fluke. The disease has a high incidence in the tropical regions of Southeast Asia. Men and women are equally affected. The fluke resides in snail and fish, which are intermediate hosts. Humans are definitive hosts. Humans become infected by eating raw or undercooked freshwater infected fish and snails. After an infected fish is eaten by a human, the infective larva, metacercari, develop into juvenile flukes in the duodenum. The hermaphrodite fluke ascends through the ampulla of Vater into the intrahepatic biliary radicals. Here they mature into adults in about a month and may reside for many years. The flukes in the bile duct induce epithelial hyperplasia, periductal fibrosis, and sometimes dysplasia causing cholangiocarcinoma. The bile ducts undergo cystic dilatation also. Strictures can be found anywhere in the hepatobiliary tree. These usually involve the intrahepatic major hepatic ducts, most often the left hepatic duct. The eggs or dead worms act as a nidus for stone formation in the intrahepatic bile ducts, gallbladder or common bile duct. Bile ducts become thickened and dilated in late stages. Mucin produced by the parasites makes the bile lithogenic. The dilatation of intrahepatic bile ducts may lead to cholangitis, liver abscess, and hepatitis. The gallbladder is involved in 20% of cases. Choledochoduodenal fistula, acute pancreatitis, liver failure, cirrhosis, and cholangiocarcinoma are serious complications. The potential patient may remain asymptomatic for many years. Clinical features include fever with rigors, malaise, anorexia, and right upper quadrant abdominal pain. The typical patient is a 20 to 40-year-old Asian person of a low socioeconomic background who presents with repeated episodes of cholangitis. In older patients and long-standing cases, the clinical picture may consist of fever with rigors, obstructive jaundice, and biliary colic known as Charcot's triad. Jaundice and pruritus are uncommon because the biliary obstruction is usually incomplete. The obstruction of the pancreatic duct by an adult worm may lead to acute pancreatitis. In patients presenting with acute pancreatitis, the pain may be in the epigastrium as opposed to the right upper quadrant. Patients who have experienced recurrent episodes typically report 1 to 2 episodes of fever, jaundice, and right upper quadrant abdominal pain per year and a history of prior biliary surgery, endoscopic procedures, and percutaneous biliary drainage procedures. Patients may present in the emergency room with gram-negative bacteremia or sepsis and organ failure. A pyogenic liver abscess and biliary malignancy may also be a presentation of recurrent pyogenic cholangitis. There is usually leukocytosis. Liver function tests are abnormal in advanced cases with biliary obstruction. The diagnosis is confirmed by the examination of a stool or duodenal spirit which may show the eggs or adult worms. The anatomic distribution can be evaluated through a combination of ultrasound, CT scan, and direct cholangiography. Magnetic resonance cholangiopancreatography is a non-invasive test for the same purpose. Ultrasound scan may demonstrate characteristic uniform dilatation of a small peripheral intrahepatic bile ducts with only minimal dilatation of common hepatic and common bile ducts. In contrast, the common bile duct is more commonly dilated when the obstruction is caused by stones. These findings can be confirmed by endoscopic retrograde cholangiopancreatography or ERCP. The subclinical form can be detected by screening ultrasound of the hepatobiliary system. The drugs of choice for clonorchiasis are praziquantel and albendazole. Medical treatment can be curative in the subclinical and early stages. Major challenge for the surgeon are stones in the gallbladder and in common bile duct. The goals of surgical treatment is to clear the biliary tree of stones and to bypass, resect or enlarge strictures. Cholecystectomy and exploration of the common bile duct with repeated washouts to remove stones, biliary debris and sludge should be done, followed by a biliary enteric bypass, such as choledochoduodenostomy. In prolonged and recurrent disease, a Roux-loop choledochoduodenostomy is performed. An excess Roux loop is created by extending the end of the Roux-en-Y hepaticcholangiohepatitis to the skin or subcutaneous space, which allows removal of any future stones by the interventional radiologist. For poor risk surgical patients and those who have failed to respond to surgical treatment, percutaneous transhepatic cholangioscopic lithotomy is used. A stone recurrence is common due to the presence of biliary strictures. In the subclinical stage, the disease can be treated and even cured by drug therapy only. Other potential procedures are a strictureplasty and partial hepatectomy. By treatment in the subclinical stage, the risk of developing cholangiocarcinoma can be eliminated.